Good morning, everybody. We are going to describe today the pathology of the skin and eyelid. And we shall start with an anatomy reminder of the eyelid. You all know from your study of anatomy and revision of anatomy and surgery that the eyelid is composed of two lamellae of 4 layers. The anterior lamella is the skin and muscle, and the posterior is the tarsus and conjunctiva, and all meet at the mucocutaneous junction at the lid margin, where the openings of the meibomian glands exist, as well as the 2 or 3 rows of lashes in the upper eyelid and in the lower eyelid. And this is a diagrammatic presentation of the same section, where you can see the inside of the eyelid aligned by the conjunctiva, covering and closely adherent to the tarsus, and anteriorly is the lamella of the skin and muscle. Now we shall start with skin pathology, and to describe and discuss skin pathology, we must know something about the histology of the skin. And here is a section, rather 3-dimensioned, of the human skin, and it is, as you can see, composed of 4 layers: the epidermis, the dermis, the hypodermis, and the adipose tissue. Here we go. The dermis is the first layer, and this is very important in our pathology of the eyelid. It's composed of 5 layers. The first is the stratum corneum, or the keratin layer. The second is the stratum lucidum, or the clear layer, followed by the stratum granulosum, or the granular layer, then the stratum spinosum, or the prickle cell layer, and the stratum basal, or the basal cell layer. So keratin, clear, granular, prickle, and basal. Keratin is the one on the outside, and the lucid layer is the clear layer, followed by the granular layer. It's a cellular layer, and then the spinosum or prickle cell layer, and finally the basal layer, or the basement membrane of all this epithelium. And the second stratum of the skin is the dermis, and the dermis is a thick layer of connective tissue with a papillary distinct layer next to the epidermis, and then the reticular layer. This layer lodges all the skin appendages, like the hair follicle with its adjuvant sebaceous glands, sweat glands, blood vessels of venules and arteries. And then we come to the hypodermis, and the hypodermis is the superficial fascia in the whole covering of the body, followed by the adipose tissue layer, which is lacking in thin skin, that is the type of skin of the eyelids. We don't have an adipose fat layer in the skin of the eyelids. The skin appendages then are, as I said, located in the dermis, and these are the eccrine sweat glands, the hair follicles, and the sebaceous or oil secreting glands into the hair follicles. Now we come to the pathological description of skin lesions, and as you can see, a skin lesion might be a flat area of only color change with neither elevation nor depression, and this is called a macule. This is called a macule, and it's an example in freckles. If this change of color is elevated but less than ½ centimeter in diameter, this is called a papule, and its example is allergic eczema. if the diameter exceeds 0.5 centimeter and comes to 1 centimeter or less, extending then into the deeper dermis, this is called a nodule. And if it is bigger than 1 centimeter, this is called a tumor. And example here is squamous cell carcinoma, and there is a mole. A mole is the nevus or the benign melanoma. So a skin lesion might be a macule, no elevation, a nodule, elevation of less than 0.5 centimeter, elevation and deeper penetration into the dermis from 0.5 to 1 centimeter, and elevation more than 1 centimeter, and this is a tumor. In the mucous membrane, a flat elevation on the surface is called a plaque, and it may sometimes occur on the skin as well, like thrush, like when there is exudation in cases of herpes simplex, for example. And there is the wheal, which is a type of plaque. The wheal here is a type of plaque, but with surrounding edema. It's not just an elevation, but surrounded by edema. If this is filled with fluid, a small blister filled with fluid, this is called a vesicle. And if a vesicle is bigger than 0.5 centimeter, it's called a bulla. And if it is filled with pus, it would be called a pustule. So again, a macule is a area of change of color. Elevation less than 0.5 centimeter is a papule. Elevation from 0.5 to 1 is a nodule. And if more than 1 centimeter, it's a tumor. And an elevation covered by sort of a crust, it's called a plaque. And if surrounded with edema, it's called a wheal. If filled with fluid, it's called a vesicle. If bigger than 0.5 centimeter, a vesicle is called a bulla. And if it's filled with pus, it's called a pustule. And all these are the primary skin lesions. And when we come to secondary skin lesions, we have the scales where flakes of cornified skin layer, that is proliferation of the horny cell layer. This is called a scale. And if this scale is covered by dried exudation on the skin, this is called a crust. If there is a crack in the skin, it's called a fissure. If there is an area of destruction of the entire epidermis, this is called an ulcer. And if there is collagen laying in this area, it's called a scar. And if there is a loss of some of the skin components, it's called a skin atrophy. So the secondary skin lesions are the scales, which are flakes of cornified skin. This will be differentiated from hyperkeratosis by being flakes, not a complete layer, just small crusts. And by crust, pathologically speaking, there is a dried exudation, a fissure is cracking, an ulcer is destruction of an area, scar, laying of fibroblasts, and collagen production, and atrophy, loss of some elements. Scales like in psoriasis, crust like in impetigo, fissures like in athlete's feet, decubitus, or what we call bed sores are ulcers, an example of ulcer. Scars like surgical healing, following surgical healing, and atrophy in paralysis. Okay. Now we come to epidermal lesions, not whole skin lesions. And epidermal lesions are hyperkeratosis, parakeratosis, acanthosis, dyskeratosis, and acantholysis. Let's start by hyperkeratosis, and this means thickening of the horny cell layer, which is the stratum corneum that we described, the keratin layer. So thickening of the stratum corneum or the horny cell layer is called hyperkeratosis. And if there is incomplete keratinization with nuclei of the cells retained in the keratin layer, this is called parakeratosis. And if there is a thickening in the squamous cell layer or the stratum spinosum or the sprickle cell layer, this is called acanthosis. And if there is keratinization elsewhere than the superficial layer, that is keratinization of individual cells within the layers of the skin, this is called dyskeratosis. If there is separation of epidermal cells with loss of desmosomes, this is called acantholysis. So we have the terms hyperkeratosis, parakeratosis, acanthosis, dyskeratosis, and acantholysis. Now, hyperkeratosis, this is more clearing, more explanation of the terms, is a thickening. Hyperkeratosis is a thickening of the horny cell layer. As you can see, keratin is in excess than the normal thing. This is an actual histopathological study. Hyperkeratosis occurs in the skin as a mechanism, physiological mechanism for normal protection against rubbing, pressure, and local irritation. And then parakeratosis, where the layer of keratin retains some nuclei. Normally, there are no nuclei, as the squamous cell layer, when the cells die and become keratinized, they lose their nuclei. But this is a sort of a premature keratinization of a superficial cell layer, and this is called parakeratosis, where the nuclei are retained in the keratin layer. Here, as you can see, the keratin layer has some blue nuclei in. And this condition occurs in benign skin diseases like dermatitis, malignant neoplasms, as squamous cell carcinoma. So in squamous cell carcinoma, we can describe parakeratosis. We can find parakeratosis and dermatitis, which occurs, for example, in thyroid eye disease. There is parakeratosis, meaning nuclei retained in the keratin layer. Here we have acanthosis, which is thickening of the squamous cell layer. It's thickened. The squamous cell layer, this one here, is thickened. As you can see, thickening of the squamous cell layer, the stratum spinosum. And acanthosis may occur in conditions like forest nevus, sometimes in trauma, psoriasis, in warts, and in dermatofibroma. Forest nevus is the most prominent one. And then we come to dyskeratosis, and on the reverse, here there is keratinization of individual cells in the deeper layers, not cells migrating into the keratin with their nuclei, no, the reverse, keratinization occurring in the deeper layers. And this can occur in some malignancies, in warts, and there is a congenital variant that the dermatologists describe and diagnose. Acantholysis, where there is separation of the epidermal cells. As you can see, the cells even did not stand the normal process of histological preparation due to loss of desmosomes, which are the junctions between the cells. And acantholysis can be seen in pemphigus, vulgaris, or pemphigoid. It's absent in the pemphigoid, so it's useful for differential diagnosis. So in cicatricial ocular pemphigoid, if it affects the skin, there is absence of acantholysis, and this is a constant finding in pemphigus vulgaris to differentiate both.